So once again, good afternoon. Thank you again for the opportunity to present our case. We'll bring a slightly different and simpler case in terms of technique, nothing compared with the previous cases that we've seen, but it's another one to think a little bit. So it's a male, a 63 years old male, with a personal history of pulmonary obstructive chronic disease, medicated, well controlled, and in 2017 went to the emergency room with a chief complaint of hematochezia with 10 days without any other complaint. Physical exam confirmed the presence of blood in the stools, and he did a left colonoscopy that visualized at the 22 centimeters from the anal verge vegetating lesion. He was discharged with indication to complete the exams and to do a total colonoscopy. The CT, thoracoabdominal pelvic CT, was normal. 2 cysts in the liver and the lesion in the sigma colon, nothing in the lungs. The biopsy confirmed the low-grade adenocarcinoma of the sigmoid colon, and tumor markers were normal. He was presented in colorectal multidisciplinary meeting, and a laparoscopic sigmoidectomy was decided and performed. The pathology revealed a tumor T3 and 0 in 25 regional lymph nodes. He was proposed to adjuvant treatment, but due to toxicity, he didn't made it. 1 year of follow-up, and the CT scan shows 2 pulmonary lesions. One there, and the other there. The exam, besides these 2 pulmonary lesions, was normal. Tumor markers still normal. He was presented in multidisciplinary meeting, and thoracic surgery decided to resect both of lung metastases. As we can see, confirmed that were metastases of the primary colon operated. He was proposed again to adjuvant treatment, but due to a hematologic toxicity, he didn't make it. 1 year after this surgery, a new CT scan shows a relapse in the lung. Okay. And so he is again presented in our multidisciplinary meeting, and it's decided to do a PET scan that confirms the lesion. A 12-millimeter lesion, and it's decided to do SRBT. This year, the same patient repeats, so 4 years after the primary lesion, repeats a CT scan. There are no alterations in the pulmonary scan. We still see the cysts in the liver. But then, in the tail of the pancreas, we see a lesion there.
Here comes the pancreas.
So and for the first time, the CEA is double than the normal. So we have no alterations in the lungs besides the fibrotic alterations due to the surgeries. We have this hepatic cyst, and we have a 15-millimeter lesion in the tail of the pancreas. So we order a PET CT, and the PET CT shows in the tail of the pancreas an hypermetabolic lesion. So what would you do in this case now?
So, Ricardo, just one question. It is not a highly hypermetabolic lesion. It has a 3.9 SUV. What was the behavior of the SUV after injection? Can this be a benign lesion?
No, this is a delayed enhancement. It's a delayed ISUV.
Okay.
It has 2.6 and then 3.9.
And the liver cysts were present before, they're not...
Yeah, were present since the beginning. Perfectly stable,
Okay.
2 cysts, the max size of the...
So the question is whether it's a metastasis from the colon or a new tumor in the pancreas. Right?
Exactly. That was our doubt.
So, please?
Are you saying that the primary lesion was in the pancreas just 2 or 4 years ago?
It was in the distal sigmoid colon.
Well, you've got the meta in the lungs.
Yes.
What was the primary source of it, you think?
The primary source of the lung metastasis?
The lung meta,
It's from the colon.
from the colon.
They were resected at the first time, and pathology confirmed that was from a colonic origin.
So it's reasonable to think that this pancreas is the same. Who has experience with pancreatic metastases from colon cancer?
It's not very usual. That's because our doubt.
You could propose endoscopic ultrasonography with biopsy.
It's
Or just resected?
Just one thing. The cases of pancreatic metastasis from colorectal cancer that we have seen in our experience were always
the surface.
direct invasion of the tumor or a local recurrence, never metastasis. What was the histology? Do you have a biopsy of the lung tumor?
Yes,
It's the same. That's
we
correct.
have. I can show you. We have the histology from the lung, and it's a metastasis, as I showed you. Here it is. So this is the necrosis, and then the colonic pattern in the lung. And the primary was 22 centimeters. It's a distal sigma colon. So theoretically, it's far away from the tail of the pancreas.
It's 4 years later.
And 4 years later, yes.
Marc?
Yeah, we have some experience with metastasis. You see once in a while colorectal metastasis in the pancreas, and you can treat them just as liver metastasis, actually just do a resection. The question, of course, is this a metastasis or is this something else? The end is, if you cannot prove it by biopsy, a metastasis, you would get it out. If it's a pancreatic carcinoma of the tail, you will get it out. So you can also imagine what would be there that you could have left. So
Finally, the question is, will the biopsy change something?
I don't think so.
That was our thought. But before, we ordered a pancreatic MRI just to see the location. And the location is not on the surface of the pancreas. This is not a local relapse. This is a lesion that it's inside the pancreatic tissue.
We didn't see it.
So we tried to do a CT guide biopsy, but it was not possible due to the location of the spleen and the transverse colon. And so we presented in our meeting, and we decided to perform a laparoscopic distal pancreatectomy, which the pathology revealed normal pancreas and inside the pancreas an adenocarcinoma, and immunohistochemistry showed the colorectal origin of this lesion. So we presented in multidisciplinary meeting. We are running now some tests of this metastasis to try to choose a chemo that the patient will tolerate, because he didn't tolerate the two first regimens that were prescribed. And thank you.
What did you do with the spleen? Splenic pancreatectomy?
Yeah, left.
Was very distal. Any questions?
Because with the doubt of a primary in the pancreas, the spleen should.
And don't you think if you really want a biopsy, the best way is endoscopic ultrasound? We don't do any percutaneous biopsies of pancreas anymore.
This was telltale. The stomach was not near, so it was ruled out also by the gastroenterology. Thank you.
Any comments about pancreatic metastases? Jean-Robert, par exemple? Ou... René, I think we have a few, we have 2 or 3 now. We did one recently.
Never seen pancreatic metastasis from colon cancer.
I think we've seen one recently.
Very rare.
Yeah. But it's very rare.
Yes, very, very.
But it exists. It's usually from the kidney. Pancreatic metastasis from kidney cancer is common. Not common, but it can happen. Philippe, you have experience with pancreatic metastases from colon cancer?
No, never seen.
Okay.
So just a practical question. Do you believe then this is a pancreatic metastasis of a colon cancer? And the histology is similar to the histology that you have on the...
You don't believe the pathology, right?
No, I do.
You have a good pathology.
No, they have the final word. The final word is in the pathology lab.
Of course.
A good pathology.
Eduardo, you just joined us. Have any comments? You have no sound.
Microphone.
Eduardo.
Microphone.
Eduardo, you are mute. Okay. Okay. We can hear you laugh. Okay.
You.
Okay,
so salut everybody. Now I have no comments. I never saw metastasis. Who knows that? When I was the director of the Curi Cabral in Lisbon, I never saw a metastasis from cancer, colon cancer. But you have operated someone from kidney metastasis for kidney tumors, even 15 years after the operation, initial operation, a long time after the surgery of the kidney and the pancreatic metastasis. But okay, I enjoy that you have operated this patient quickly.
Thank you.
It's the first time in our department.
That's always the first time for everything, for everybody, and for every disease, for everything.
Okay, we are done with the pancreas cases. What?
I think we can close the session and move on to the other one.